Shall we be everybody happy to begin? Okay. So good morning, everybody, and welcome. I'm Councillor Bridget Folwell, and I'm Chair of the Corporate Parenting Board. Can I just remind everybody about the use of microphones? This is being recorded and shared, so we must not discuss individual cases about children and young people, as this would need to be done with an exempt business. Also, as this meeting's being recorded, please could you say your name and title each time you address the meeting? That's okay. I'm pleased to welcome Louise Harris-Smith, Simon Hester and Rachel Lachlan. Lachlan, sorry. Lachlan. Joining the meeting today, and we will be receiving updates from them on related NHS activities after the main report and responses to questions, although they may be interlinked. So do I have any apologies, please?
We've got apologies from Councillors Matt Bell and
yeah.
Do you also include Councillor James?
Thank you. Are there any declarations of interest? No. I have the minutes from the last meeting that was held on Tuesday the 10th of December. If there's any comments? No, okay, so they're approved. And item 5, there has been no public participation. And can I just welcome Matthew Chislett, who's online. Thank you for attending, Matthew.
Thank you.
So I'm handing over now to Paul Dempsey. To introduce the item.
Okay, so I think colleagues will remember this is the annual health report for 2023-24. So colleagues, just be aware that it is a year on from the end of the period which Louise and colleagues are going to be reporting on. First came to the formal board meeting on December the 10th, and we deferred it because we didn't have health colleagues in the room to talk us through it, and taken some time, apologies colleagues, to arrange this extraordinary meeting to hear health colleagues talk us through the report. So thank you very much for attending today, and carry on, everybody.
Okay, thank you. So I'll hand over now to Louise Harris-Smith, Health of Children in Care and Emotional Wellbeing of Children in Care, who's going to present the report.
Yeah. Thank you. So Louise Harris-Smith, I'm a designated nurse for children in care and care experienced young people, and I work for NHS Dorset. So as Paul mentioned, this is a report based on the information held from 2023 to 2024. What I have done, because the information is slightly historic now, is kind of try and give you a bit of an update on the main points and the highlighted points that I had prepared for the presentation last year. So in that time, 150 children came into care, giving a total of 1,000 children accommodated across both BCP and Dorset, and that showed an increase of 3.8% children. 2024 to 25 shows that consistent numbers of caseload throughout the year, sitting around 445 children for Dorset. In terms of care leavers, we had a rise to 674 care leavers. That's what we've recorded. And we also now have 164 children placed in Dorset, not Pan Dorset, in Dorset by other local authorities, which I thought was useful to note. We wanted to raise about IHA performance because during that reporting period, the IHA attainment had improved throughout each quarter, from 56% to 81% by Q4 in 2024. And collaborative performance meetings have been key to this improvement, which we'll talk more about. In 2024-25 Q3, showed a return of 78.4%, and year to date 106 initial health assessments were required. Only one was delayed to first available medical advisor appointment. What some of the other highlights I wanted to pick out was the multi-agency pregnancy pathway. I know we'll talk about that, as that's one of Duncan's questions.
Yeah.
And we also want to talk about the dental access for children in care and what the update is and the progress is for that, and the serious violence duty role for Dorset as well, which has proven to be quite successful. Of note, out of area delays remain an issue, both IHA and RHA completion. NHS England have developed a data set which is starting to address the variation across the country. We know this is a national issue, and requires data submission both from our providers, University Hospitals Dorset and Dorset Healthcare. And we also wanted to highlight the response to need for the increased support for our care leavers. And I think in Dorset we do that quite well. We work really, really closely with our local authority partners on working out how best to support our care leavers and where the themes and the gaps are rising for them. And as part of that, I want to talk about the PCN pilot that we've commenced. So at that time, the areas for development were a new Children in Care Health Forum that focused just on the health of children in care and drew together common themes and goals with all those working with children in care and care experienced young people. And we wanted to work with dental commissioners and the integrated care system to provide dental access to children and care leavers. And we wanted to hopefully act upon NHSE advice and data requests for out of area health assessments. And that's the data set that I was just mentioning there. So those are my highlight main points. I didn't know whether you wanted me to go through some of the questions now. What would you prefer?
It's what you prefer, actually. What's easiest for you, to be honest?
Yeah. So if we start with Councillor Parry, your questions around initial health assessments. Are you happy to do that now? Yeah. Okay. I suppose that the question you put in there was about it being a legal requirement. You're absolutely right, and these should be completed within 20 days. And your comment is the timeliness of initial health assessments was unsatisfactory. I think that it would be quite useful to think about data over a period of time. I didn't know if you wanted to hone in on a particular quarter or a particular data set. Yeah.
So I suppose, sort of thinking about the timeliness of IHAs, there are lots of reasons why IHAs don't happen on time, which are not all due to one particular area or one person. So when we report on our data, we report on the reasons for delays as well as the actual numbers. So the reasons we look at when we're talking about the IHAs are the notification and consent, which we should receive in 5 working days. So bearing in mind that we've then got 3 weeks to organise an IHA, if that's late, then it's quite difficult for us to get the IHA in time. Sometimes we get a notification after 20 days, so it's clearly impossible for us to do that in the 20 days. We also look at sometimes young people on the day decide they don't want to come to the appointment, they're not brought, or there's a miscommunication in their placement and they don't turn up. We also look at sometimes appointments are declined because there's something else going on that day. So trying to juggle getting all the appointments booked in 3 weeks. If we allocate an appointment to a child and then the carer says they've got something else they have to attend, or the child has an exam, or the child has, we've had children that started college on that day, and obviously it's got to be child-centred and it's got to be important that their needs are respected. We also have children who have capacity to decide whether or not they want to attend, who say they don't want a mental health assessment and would therefore be entitled to refuse to attend those appointments. And they tend to be the older teenagers, because we would want the social workers to have explained the IHA process to them and them to have been given the opportunity to elect to come or not. And the other thing we report on, as Louise said, is the capacity of our service to see children. And in this year, from April last year, there's only one child who we've had to see after 20 days because we didn't have an appointment. And that may have been because somebody was off sick. And we can't plan for that. We're all human beings. So if a doctor is off sick on that day, then the appointment gets cancelled. So there's a whole variety of reasons. And the way we work, we meet with Louise every month to discuss the performance data, to discuss the reasons, to discuss the issues that are resolvable. We also have, Louise has a very close relationship with our admin staff. So whenever anybody declines an appointment, there's really strict instructions for our admin staff to contact Louise to see if she can do anything to intervene to try and get that young person to the appointment. But sometimes we have to accept, particularly in the sort of summer months, if we have a young person coming into care now who is 15 or 16 and they don't want to come to an appointment in the middle of their GCSEs, then we would still offer them an appointment afterwards, but it won't be within 20 days. And I think that point's important too, is that just because they're not seen in 20 days doesn't mean they're not seen. So some of them will be seen at 22 days, 23 days. And I did a piece of work last year looking at all the children in a 2-month period who had IHAs after 20 days to look at what came out of those appointments, what medical issues were raised, what clinical issues were there, and went through all of those with our own doctor. And there wasn't anything there that we felt, had those children been seen within 20 days, would have been managed differently or made a clinical difference to that child. Obviously, I haven't done that for the whole year, and I'm not aware of any that have come to light since then. And we would expect foster carers, if they're concerned about a child's health acutely, if they're unwell, to take them to the GP. This is not in place of managing any acute medical conditions. This is a holistic assessment of all their needs going forward, things they may have missed out on, if there was neglect, things that they may not have had access to, and it's making sure that those things are present going forward. And the whole, if you read the statutory guidance, the whole point is that this is available in time for the first review, which is also supposed to happen at 20 days. And we've had some discussions amongst ourselves about sometimes those reviews happen quite early before the IHA. And so even though we've done the IHA in 20 days, the review's already happened. So we've been doing some work with Louise and her team to try and make sure that the IHAs if the review happens after the IHA, even if it's within 20 days, if that makes sense, because the whole point is that everybody is looking at the child holistically to make sure their needs are being met.
I'm back on a couple of points. Thank you. So I'm pragmatic enough to accept that there will be exceptions to the rule of 100%. Okay, I think we all understand that.
Yeah.
You give.
Yeah.
But the figures dropped dramatically to 56%.
Yeah.
And they have risen back up to 81%, I think you said.
Yeah.
Clearly, you have done something different in that period of time to turn those figures around. It hasn't happened by magic. Is that a sustainable improvement, or are we going to see that as a roller coaster going forward? And my point to officers of Dorset Council was something else that you said, which was a failure to inform you that there were children in care who were eligible or required to be added to an appointment date for initial health assessments. I'd like to hear from our officers why that happened, what measures have been taken to address that, and assurance that we'll have a better working relationship going forward. Is that fair enough?
Yeah.
Please,
Yeah.
respond.
We will see a drop in the numbers, and we have seen a drop in the number in the performance again. We understand that really well. So, for example, last month's report related to 6 children, and of those, 2 children received their initial health assessment on time. One of those children, there was a delay in receiving consent. Where we have a child who is subject to an interim care order, then we have the authority to provide that consent. This particular child was accommodated Section 20, so we don't share parental responsibility, and as a consequence, there was a delay in having receiving that consent. However, for that particular child, that child has now returned home, but remains within our numbers of children because the child was still in our care at the point at which we would have ordinarily undertaken that initial health assessment. Then we have 3 other children, 2 of which were placed outside of, are living outside of Dorset with family relatives. So that's a really good thing that they are actually living within the wider family network. However, the impact of living outside of Dorset then impacts on the timeliness. However, both of those children have received their initial health assessment now, and there was a delay of 6 days. And then the final child, unaccompanied young person living in Sandwell. And all of those, when we meet on a monthly basis, we track through really, really closely, has also now received their initial health assessment. But the timeliness for that 8 days over. So we have an absolute eye on how long those initial health assessments are taking. So we don't just say, oh, well, actually they're out of time, but we pay attention to making sure that they are completed in as quick a time as possible.
Would it be a reasonable position to adopt then, say that out of county placements are potentially more difficult to carry out initial health assessments?
Yeah.
And that is a national picture.
Can I say something?
Yes, please.
Yeah,
Yes.
So I sit on the Cornwall Health Board, and I think that when we talk to other people, there are areas that don't get any of their IHA done in 20 days, their own and other people. And because there are so many different organisations, health organisations doing medical, it's different everywhere. So we have, my app is fantastic, but we have sort of list, you have to contact them, we have to send all the information. So there's added layers built in if they're out of area. But also, if other areas already have, a 3 or 6 month wait for an IHA, that our children join with that group of children that are waiting, and we don't have any control over that. We do discuss them, and Louise and I try and liaise with our counterparts in different areas, but it's very difficult because we don't have any control over other areas to manage that. But out of area placements are very difficult for us to manage, and it's the biggest reason for delays.
Would they be invited back to Dorset to have an initial health assessment?
If they're an hour away, so we generally bring back children from Southampton or from Somerset, particularly if they're going to be out of time. But if they're, some of these children are in Manchester, or it's not fair or feasible to expect them to travel back to Hall for an assessment and then be able to undertake a sort of holistic assessment that, of talking about their emotional needs and all sorts of things after that.
Formative data.
It's not appropriate. So it's got to be in the child's interest. But we definitely bring back children from out of area if it's feasible.
Interesting, thank you.
Okay.
Did you want to say anything?
Well, just to add that it's a
Sure.
partnership approach. I think you've got
Yeah.
a really balanced, rounded answer from colleagues across the room. And there have been occasions where our bit of partnership has fallen down. So we have to notify our health colleagues within 5 days, and we sometimes haven't got that in time. And so that's not helping with that 20-day timeliness. So we have to make sure our house is in order to give as much time health colleagues. So we have a rigorous process of monitoring that now. Every time a child comes into care, we chase in, Louise is leading, chasing colleagues on making sure that the notifications go to the health service. So as I say, it's a partnership approach, and we have a key part to play in that as well.
I may come back on that point then. Are you confident, along with the cabinet member for children, that you have sufficient resource in order to meet these requirements? Or is there any ask of you to the board that support additional resource requirements?
I think we have sufficient resource to do that. Yeah.
Can I just say that the notification is not as, the bigger problem is consent for the reasons Louise has said, that if a child is on section 20 and the consent has to come from the birth parents, if the birth parents aren't able to do that for various reasons, that's really difficult, and it's not in anyone's power to be able to fix that easily. And consent is a bigger problem than notification, for sure.
Yeah.
Thank you. Just to add in the last bit on that, what's been really key is Louise's determinants to actually make a difference with this. And that's the difference we see across Dorset as well. We know that we've got Louise to ask and to follow through some of the requests that have been made, and she does that robustly.
Thank you. So would you continue?
Okay, so Councillor Parry, your second question was about the health passport.
Yeah.
Which no data is reported. So what are the statutory requirements and when can we expect to see reporting commencing? So the health passport is a Department of Education requirement and is reported monthly to Dorset Council. So we know that this, from a kind of operational perspective, the actual process of health passports have been reviewed lately because our young people are telling us that they can't remember having them. Some places they're called health histories and health passports. So the Children in Care Health team at Dorset Healthcare reviewed that, have revamped the whole process in partnership with Dorset and with young people as well, and have made it a little bit more memorable for them. So they have their own copy of it, and it's very child-led, and they have it sits with their on their records as well. I didn't know, Louise, if you wanted to say anything more about the reporting on health passports, whether you wanted that as part of the annual report. I'm happy to put it in there because we report on it monthly, but I wasn't sure what.
I think my question amongst it was, it obviously shows as a line in reporting, but has no data against it. So it would seem odd that there is no. Why is it there if we're not? There's no data, and if it is there, we've got the data against it.
So I think so. Paul and myself actually discussed this morning, and trying to be ahead of ourselves on questions, and we can see how many health passports have been undertaken, but actually that doesn't mean anything to us, because actually if we were expecting 50 health passports to be completed and we only have 10, well, that's not what we're counting at the moment. So I think I'll have a conversation with Matt and with Jane McLennan to see whether we can make that a much more meaningful data capture.
Ultimately, my questions there would be the awareness amongst our children and young people,
Yes.
the sheer existence of the health passport. What measures are going to be taken to
Yeah.
improve that?
Absolutely. I think the nurse that we have who sits at Kirtleton Avenue spends a lot of time there. Young people would say, "Oh yeah, I do have that, but I just don't call it that." So I think, Matt, would that be your understanding as well?
Hi, all. Yes, Matthew Chislett, Service Manager for the Living Care team. Absolutely. We are seeing them on file as well. If there are any questions or queries around it, the PAs will step in and look at that. We'll obviously bring in Abby, who's a huge support to our service. She comes into Kirtleton regularly and arrange those discussions with the young people. The terminology is absolutely right. To our young people, it may be known as something else, or not fully understanding the health passport as in the language we use.
Thank you. Let's continue.
Thank you. So moving on to Councillor Sutton's question, the dental comes up here. So the question is around dental risks being removed from the register. Does it need to be re-added to the risk register, and also about the availability of NHS dentists? So I thought it might be quite useful to explain what the progress has been in terms of dentists. So back in 2023, I did write a paper to our commissioners, our dental commissioners, because the ICB received delegation for dentistry from NHSE to ask around some of the escalations that had been raised for our children in care who don't have access to a dentist, or where the foster care is having to pay privately, because we felt that it was inequitable that our children in care were not receiving dental access in the same way as their universal peers. This was accepted, and a scheme was launched in January. It obviously started a lot earlier than that, but the actual scheme was launched in January, where we have a number of dentists on board who have agreed to see and prioritise children in care specifically, and care leavers. So not just children in care, but for our care leavers as well, who don't currently have access to a dentist. And this is for an initial treatment, and the plan is for them to stay on the registration on the books of that dental practice as well. So it's a huge leap forward. And what we aim to see now is a really good improvement in our data around children in care receiving and being up to date with their dental access, but also receiving the treatment that they need. There is still the route of, if they're in pain at any time, for anybody, you go through 111 system, but this was a scheme specifically for children in care. To date, we have had 12 referrals through that process. So Dorset Healthcare team administer the process. We've only had 12 from Dorset, and that's 5 children in care and 7 care leavers. Work is ongoing with Tony College around those children who are trying to seek out those children who perhaps don't want to go to the dentist and why, and trying to sort of move on to those different group of children. So it's a really positive position to be in.
So Councillor Bolwell, I forgot what's going on. Sorry. Yeah. So the dentists that you have who will specifically do this, are they around Dorset, not just like, so I'm from Bridport, so if we've got children and families who have to go all the way to, say, Blandford, for instance,
Yeah,
they're in the different areas, are they?
got one in Bridport.
Good.
So we've got Bridport, Wareham, Corfmullen. We're working hard to get Weymouth and Dorchester. It's difficult because the dentists have to actually want to do this.
Yes.
And they do receive remuneration, additional remuneration for seeing our children. And that's the hook. So we're still working on it. From my perspective, it's a win-win for them because they may already be seeing children in care. So they might as well receive the extra payment for seeing them. And that's why we're still working on across the road. I think there's the My Dentist next to the Dorford Centre. That's where we'd really like to, because they're already supporting children in care. Yeah. So it's just helping them to understand what they get out of this.
Yeah. Oh, thank you. That's really positive. Claire?
Councillor Claire Sutton, Cabinet Member, Children's Services Education Skills. I don't have a lot to say actually, because your answer was kind of what I was hoping you were going to tell me, because obviously we know that dentistry is a massive challenge across the board. So the fact that dentists are prioritising children in care and care leavers is obviously the news that one wants. Weymouth and Portland, I'm sure you're on it, but it doesn't sound you're using all the tools in the box. Are there any other tools you could be using?
So I work closely with our dental commissioners within the ICB, and we do the same each time, send them out information, target them individually. So short of actually stepping foot into that practice, which is the next step, because we really do need to make sure we've got Dorchester and Weymouth on board with this, because as you know, a lot of our care leavers are living in Weymouth, so it would be great to try. And when we want to increase numbers as well, and that's down to our colleagues within the local authority to kind of let's get this pushed forward, and the scheme's there, let's use it, because if we don't, the dentist could be saying, well, this isn't actually worth our while, so we need to use it.
Matthew's got his hand up. Matthew.
Hi, thank you. I just wanted to reinforce actually the young people in the care leaving service who've needed it. We've not had any pushback where we've needed it. We've got it in a timely way. So the system from our perspective is working, and if there's any issues around transport or anything like that, we have PAs. We will make it work to get them into whatever surgery they need. All my staff are aware of it, and we continue to push, but there's a lot less noise around this, and it seems to be really working for us, I would say. Thank you.
Thanks, Matt.
Thank you. Yeah, would you like to continue?
So then there was a question around initial health assessments. Do you feel Okay, lovely. And then increased emotional health support for care leavers within primary care networks. Following Blandford PCN pilot, 4 more PCNs involved, with the hope that more PCNs will prioritise this vulnerable group. What does involved mean? Great question. This is something that we're really positive about, really proud about. Our primary care networks have now increased to 7, and I think, correct me, is it 17 or 18 PCNs that we've got across Dorset? I think it's 18. I think it's 18, and that covers 30 GP practices. And so what are following the Blandford example, where sadly a care leaver died, the Blandford group practice decided that they wanted to step up and do something more to support the care leavers. They started recognising that actually care leavers needed that. So we stepped in to support them with, alongside Dorset Healthcare and Abby, who's been mentioned before, who's our care leaver transition nurse. So we support the PCNs that want to step forward with putting forward additional roles to specifically support care leavers. And this is about encouraging them to come into the surgery, to access the surgery. Some of them might not feel that actually they feel welcome. So we want to make these PCNs and these practices care leaver friendly, and to also upskill the practice staff. So not just the GPs, but all the practice staff around the needs of a care leaver, vulnerabilities of a care leaver, and why they need to be seeing them as a kind of a group to prioritise. So in support of that, we meet with them 6 weekly, each of the PCNs that have stepped up, and it's to kind of offer support to them and shared good practice. We offer them training. Dr. Souza and I, who's one of our named GPs, have done some online training specifically for GP practices, and that's what they're going to be targeting during their protected learning time. So whilst we haven't got all the PCNs on board yet, that's work in progress. And each time we have one of these six weekly meetings, another PCN has stepped on. So it's a really positive thing to be part of, and I know for our care leavers we've got examples where that's really made a difference for them.
Again, that's really reassuring. So you said some, but not all. How many of the 18?
7 so far, covering the 30 practices, because each PCN, their cover is different. So you could have one PCN that's just got one GP practice, and you could have one PCN that's covering 8 GP practices. So yeah, it's somebody's done a really helpful, almost like a London map, underground map of all the PCNs with all the GP practices in it, and that's really useful at sort of targeting. So again, we'll be able to specifically, next week, Weymouth and Portland are on board. They're not quite yet seeing why they need to be part of the project. But next week, Dr. Souza and myself and Abby are going to see them to give them a bit more information about it.
It's really positive, thank you.
And then the question around reducing serious violence duty role within Dorset, what impact has via monitoring has had to date, and if making a difference, has any progress been made promoting the sufficiency of the role? So this role came about and was launched in June last year, and was funded by the OPCC money for serious violence duty. And it consists of one nurse working 30 hours just in Dorset, not Pound Dorset, just Dorset. And she identifies or has referred to her those children who are starting to show signs that they might need some more targeted support in terms of their mental emotional health, and they're maybe going missing, they might be not attending school, all the kind of signs that we're starting to think this person might need proactively before they get to the point of having to enter youth justice. And that's the point of this role, is to stop that happening. And the outcomes of it have been really positive. I can share with you the report, the final report, because it's coming up to that time, will be out shortly, and I'm happy to share that with you all, because it makes some interesting reading. But some of the outcomes that we have is that would you like me to give you an example of one of the children? Would that be helpful? Oh, yeah, it's no name. If you'd rather not, maybe not. Okay. Yeah. Okay. So it was a young person with a background of trauma, experiencing exploitation, missing episodes, like I was saying, carrying knives, substance abuse, and with some drug debt. And the nurse was able to build a really trusting relationship, and that is absolutely key to this. Is that being that one person that young person can rely on. And be consistent with, and very flexible with her visits. So she has a background of mental health. She's a mental health nurse, and works very closely with the harbour as well. And she has managed to get some really good outcomes. So previously declined health assessments. She's managed to get them to that, including CAMS for ADHD assessment, speech and language, sexual health, substance outreach team, dentist appointments, and then also work with the inclusion team to get them back into education.
That's fine. And when we have the final report, it will be kind of quantitative and quantitative.
Yes.
Assurance
All the monitoring and the data will be part of that, and some amazing feedback as well, which will include from professionals and young people themselves.
So the second part of that question is sufficiency of the role. Yeah.
So this was funded for a year.
Yeah.
It's not long enough. We recognise that. It would be great if we could try and extend that. So to that end, we have submitted a bid again for consideration at the next community safety partnership, which I believe is next week. We're really hopeful that, given the positive outcomes that we've been able to show, that lands positively.
Is there anything we can do to assist in advocating in that forum?
What do you think, Simon?
Just let us know.
I think a letter, just a quick email of support would be really helpful. I think for obviously we're all part of the community safety partnership. We are the statutory members as well.
So who will do that?
I'll take that.
Oh, look.
Thank you.
Sorry, Paul Dempsey, Director of Children's Services. Just to add, I've got the Youth Justice Board today, which I now chair, and performance report. And the performance report on there does indicate that the number of first-time entrants to youth justice has increased year on year, and this last year decreased as well. Not solely because of that professional, but it will have been a contribution amongst all the other sort of prevention activity that is happening around trying to reduce first-time entrants, and that aligns with what Lily was saying. But I will talk about how the Youth Justice Board might lobby in for that role to continue as well.
Yeah, and that we're fully supportive
Yeah.
through the Corporate Parenting Board as well. Thank you.
Thank you. Lovely, thank you. So, Councillor Bolwell. Speech and language assessments for children in care. Yeah, absolutely, something really close to my heart. We've been talking for a long time about how we improve speech and language assessments, because going back to the serious violence duty role, that's one of the things that we said we wanted to achieve in the outcome monitoring, is actually recognising that for some of these children, and I know that Youth Justice find this too, there was a high proportion of young people diagnosed with speech and language disorders that haven't been found or identified earlier. So,
and it's something like 80%, isn't it? It's very high.
Yeah, definitely. You're asking, I'm reading the wrong bit here, is there a specific early intervention initial assessment with reference to expressive and receptive language for our children in care? So in terms of when they first come into care, it is something that is considered as part of the holistic assessment.
I did wonder.
For children.
Yes, so I can talk about, so all of our people that do IHAs are paediatric trained, so they work within the Child Development Centre, so they'd either do developmental assessments or they've had training in that, so they are able to assess sort of speech and language. We're not speech and language therapists, but in terms of understanding what is normal and not normal, and then to sort of refer on via the processes that exist to have extra assessments. I think one thing that's probably a bit different between the initial health assessment and review health assessment is that we do recognise some of the children that come into care that have suffered a lot of trauma and neglect may be very behind in their development, which sometimes improves quite dramatically in a sort of care and nurturing environment. So some of that might be for the very young children that we ask the helpers to review them in 3 months and access their services if they're still concerned, because they would be the people that would be normally supporting families where there was speech and language concern. And then if there were other concerns, then they would be picked up at the RHA.
Yeah.
That would be part of that assessment as well.
Absolutely. And the feedback from in terms of the review health assessment is that there's a pathway in progress for, at the moment, it's a kind of a verbal agreement that children in care are prioritised through speech and language referral, which is great, but we need that in writing and we need a standard of practice around that. The nurses themselves are also being upskilled by our speech and language therapists within Dorset Healthcare to be able to offer that early identification so we can get the ball rolling start earlier.
Perfect, thank you.
And then it's about the young asylum seekers bloodborne virus.
So I suppose to put this in context, this was an audit of, you can only audit your own practice. So this was an audit of the practice at UHD of when we see young people for their assessment, what we were offering them, and where the audit was primarily, are the medical advisors following the process? So are they seeking the right consent? Is it recorded? Are they asking the young people? So as part of that, I obviously looked at all their records and looked at the results. So the sort of percentages of children with TB came out of that assessment. So we offer screening for infections that are treatable, and we do all of our assessments with asylum seekers with a face-to-face interpreter. And as part of that, you don't need to give written consent for these tests, but as part of our practice, we do ask medical advisors to get written consent, because it means that they've used the right paperwork, they've gone through the right process. That means that they've gone through all the things with the young person and they understand what it is they're consenting to, if that makes sense. So that was part of the audit, was to make sure they were all doing those bits correctly. I think what we understand about the young people that come into care that are asylum seekers is that there is a higher risk of them having infectious diseases, partly because of some of the countries that they originate from, but also because of the conditions they've lived in during their journeys. And when we started doing this work with asylum seekers, must be 10 years ago, it's increased over time. We looked at, where they came from. Was there a high prevalence of tuberculosis? Should we be testing them or not? But actually now we know that they've spent so much time with people from all over the world in different places, living in conditions that are not ideal, that we deem them all to be at slightly higher risk of some of these illnesses. So just as some background to TB, that worldwide 1 in 4 people carries dormant TB. So it is really common. None of the children that we've picked up in this cohort had active TB. They all had what we call latent TB, which is dormant TB, which is not infectious, but at some point in your life could become infectious. So if you are immunosuppressed, or when you're older, if you have illnesses or you take certain medications, it could cause that TB to become active. So if we pick someone up, we refer them to the TB service, they offer them antibiotic treatment to clear that. It's obviously the young person's prerogative to have the test and to have the treatment. So it's not something, we can't force them to do these things. They have to understand what it is and they will have to want to do it, which is why the consent issue is important. So what I have done is I repeated it. I didn't repeat the whole audit, but I had a look to see how many children last year came back with positive TB. And last year it was only 2 positive, so 8% of the ones we tested, but it will fluctuate. And the plan is to repeat the whole audit on the cohort from 24 to 25, but I can't do it quite yet because some of those children we haven't seen yet, and they have to have some time to have their tests and have those. So in the autumn, probably I'll repeat that audit. I don't know if you've got any questions. I'm happy to answer questions about that. But
no, I'm just aware of the time anyway now. But yeah, it's just keeping an eye on it, I think, is really important, which you are doing.
But I think it's also understanding this isn't infectious. So this is latent TB, not infectious active TB. And it's part of what we're offering to them holistically, that, you know, making sure that it's really about their health needs, and, you know, with the consideration of public health in the background. But if there is something that could be treated that's never been picked up before, then we have a duty to offer them the testing and the treatment for that. So, you know, it's about meeting their needs as well.
Thank you. Councillor Parry.
Thank you. Yes, I'll try and choose my words very carefully around what is a highly sensitive topic. This sounds like we're returning to the issue we talk about here of 84.9% of Dorset local authority unaccompanied asylum seekers being placed outside the county. And you've already suggested to us that carrying out health assessments on those placed outside the county is more difficult for a host of reasons. The issue I suppose I would want to understand from yourself and from officers is our route to resolving these to ensure that greater numbers of unaccompanied asylum seekers are placed inside the Dorset Council area, BCP area. That in itself may or may not be to their wishes and understood. Or have we really got to look at a national programme that sees better health provision nationwide for all health authorities to be able to tap into to deal with this? Because I presume, although we say that this isn't infectious, the longer it is left undiagnosed, the more likelihood of there being a serious reaction at some point down the line. I'm just trying to understand the whole relationship between out of county, unaccompanied asylum seekers who we know come with a high level of health risk. And I appreciate that is a very sensitive topic publicly, and how we meet that with ensuring that we don't increase risk amongst the general population.
So if you have latent TB, the lifetime chance of it becoming active is 5 to 15%. So it's not a guarantee, but it's more likely. It's more likely as you get older, if you're immunosuppressed. What we do with children that are out of area is that all the IHAs that come back are reviewed by our named doctor, and ultimately the doctor who has completed that report is responsible for what they've done and they've ordered in that assessment. If they haven't mentioned anything about TB or bloodborne viruses, she will go back to them and ask them if they're planning to do that. If they've said as part of the healthcare plan that's going to happen, then it's their responsibility to organise that and make sure it happens. As I've said before, everywhere works slightly differently on how, we're very lucky at an acute trust that we can do this test ourselves, and we have a system whereby we offer the children the blood test on the day that they come for their IHA, so they've still got the interpreter with them, so that it sort of is more likely to happen, and it feels more of a sort of secure process. But obviously we can't manage how other people manage their processes, but we do check that. There is also national guidance for medical advisors about unaccompanied asylum seekers, and there's also training that the Royal College of Paediatrics provides for managing asylum seekers, all of which recommends these things. So that, my hope is that, and most of the IHAs that come back, people have requested.
The best practice guidance is there. It's whether it's implemented by the health trusts across the country.
So if they haven't put it in the healthcare plan that they're going to do that, then we would follow that up for Dorset children, and then it's their responsibility to organise, arrange that, and follow up the results.
Thank you.
Oh, thank you. Moving swiftly on. I don't know if we're getting through yours, Duncan.
So the mental health pathway for children in care experience. So the update
already talked about.
Well, kind of. The update is that that is a specific children in care pathway, and what we're looking at doing with Louise and with other colleagues from Dorset is thinking about how we can improve that process. Do we need a separate strategy specifically for children in care? And that's working.
Yeah.
I think that's
Thank you.
Duncan, Councillor Surrey-House, would you like me to IHAs? Was there anything else?
So you've answered many parts of these. I think we've covered the dentistry. Pregnancy pathway, do you want to take that one?
Yeah, absolutely. So the pregnancy pathway was launched in 2023. It came off the back of a multi-agency case audit where we had 2 children in care where there were not in this area. There was a lack of support and coordinated support around them, and it led to some not particularly pleasant consequences for them. So we felt that pregnancy pathway specifically for children in care was necessary to bring together everybody working around that, their network around that young person, those young people, to make sure that everybody's talking to each other. And that's in essence what we're trying to do there. We felt was really important, including medical and maternity colleagues as well. So the pregnancy pathway was adopted as part of online procedures for social workers. Having said that, we haven't been able to evaluate it because it hasn't been used, and we think it's just been overlooked maybe, and just not been revisited, I think, by practitioners working with young people. So the plan around it now is we are developing a compassionate pathway for pregnancy, and that is a larger pathway that is to incorporate support for women who have had their children removed. There's been some significant research around in this area around women taking their own lives as a result of that. So we felt actually we could use the compassionate pathway, which myself and my colleagues within Children in Care are working on, to relaunch the pregnancy pathway as part of that as a whole. That's the plan.
And that will be communicated to practitioners with an expectation that they do it this time.
So the question is obviously how that ties
Sorry, how that ties in?
with our work in this area.
Yes.
Thank you. Anything else in particular, bearing in mind it's late?
It's not too late
No.
because I can email anything. But this,
Okay.
this is the route you risk when you ask for questions.
Yeah.
Of me, you'll get them.
Yeah.
I'm really happy to respond to you.
Yeah.
Well, I've got it all here.
Yes, thank you.
Was there anything else in particular burning?
No.
Thank you, Councillor. Right, so moving on. Was there anything else you wanted to say now around any more updates? I noticed you'd mentioned training for Corporate Parenting Board, which we welcome.
Thank you. And that's what I was going to ask, is actually from a health perspective, is there anything that we can support you with? We have talked about, and I'm due to record it later this week, some information around mental capacity and deprivation of liberty for children in care specifically. And myself and a colleague from Wiltshire are putting that training together. So we're happy to circulate that. I know that was on an action somewhere. I read it on one of the Dorset actions. I think it's corporate parenting. So we're happy to do that. But whether there was anything else that you can identify that you would like some more information that we can support you with.
Oh, that's really useful. So we can all get together as a board and I'll communicate with everybody and see what we would like, because that'd be really useful. We never stop learning. So anything else anybody wants to say? I just appreciate that you've given the time now, thank you, and really answered our questions. Councillor Quell, was there anything you wanted to ask at all?
No, I can't quite have the questions up with there. Thank you.
Oh, thank you, Councillor Parrott.
I think the main thing we were seeking was authority in all its guises. Because I appreciate we talk about the NHS, but actually I appreciate many component parts, but that our children in care are a clear priority. They are not to be an oversight or last in line or anything like that, but they are a clear priority, and that goes from those that are practicing on the front line right up to the board. That's the assurance we were seeking, or I was seeking, probably certainly.
Can I ask you, do you feel that you've received that
Today? Yes.
Thank you. Yes. Councillor Somper, is there anything you'd like to add?
Hello, Chairman.
Okay, thank you.
No,
Uh,
sorry.
Paul,
Thanks for the offer.
okay.
Warranty.
I think it's been a really, Paul Dempsey, Director of Children's Services. I think it's been a really thorough, comprehensive
Definitely.
report, feedback today. Thank you very much for that. As well as being positive, because we've heard not just what the story is, but it's a very positive story. I think looking at the performance indicators, the key performance indicators this morning for this year, 24-25, I know this report's about 23-24, almost all of them are have improved since last year. So certainly dental care up, immunisations up, annual health assessments up. As we discussed, initial health assessments up and down. Most of the other indicators, almost all the other indicators are, so that's really good. So thank you very much. It's been a much more thorough and clearer explanation of what is happening than you would have got from any of my officers in.
Yeah, exactly.
So
Yes.
we have benefited from your expertise and knowledge.
Yes, thank you.
Coming today. The other thing that I've just had a nudge about, which Councillor Sutton I think was referring to, was in relation to pregnancy, was our pause programme with mothers who had children removed from the care, and what we're doing with them through that pause programme to support them thereafter and prevent those occurrences from happening again. That is an ongoing programme.
Yeah, thank you. And I just think it's just really positive actually that we've had more time in a way, because you just we don't get this amount of time, and actually it does question, doesn't it, in a way, how we can, get more information like we've had today when we don't have that time. But anyway, it's something to maybe look at. So just to say, our next formal meeting will be on the 28th of May, and the next informal meeting will be on the 31st of July. Are there any other urgent items that anybody wants to comment on? And there is no scheduled exempt business to report. So I will close the meeting now at 11:59. Well.